Hi, Dr. Karima here, and we are shooting another video for the ADC written exam, and we are solving their own question paper which they have released. A practice paper, I would say, not a question paper. And we are on currently clinical scenario 7. For all those people who have been watching this video, you know what I'm doing in this video, and for all the new candidates, we are just solving, I'm just showing you how to solve each question which would come in your written exam. So yeah, let's just right away get into it, and we'll discuss other things later. Clinical scenario 7, and here is George, a patient who's 52-year-old, presents to your clinic with a toothache on the lower right hand side. Upon examination and testing, you determine a provisional diagnosis of irreversible pulpitis. So you have already made your provisional diagnosis. You discuss the available treatment options with George, and he elects for root canal treatment of tooth 4-6. Okay, so here we are just directly dealing with the treatment aspect of it. Already the history taken, the investigations, the diagnosis is done. So this question kind of falls in the treatment planning cluster, correct? So you have administered a highly efficacious inferior alveolar, lingual and long buccal nerve block, I and B basically you have given. After 15 minutes, George has profound numbness on the lower right lip and the right side of the tongue. So basically the inferior nerve block has acted, but tooth 4-6 feels very painful when you attempt to initiate endodontic access. Very classic situation, I would say. Even in your clinic, it's mind-boggling, it's frustrating, because you tell the patient you're going to give an anesthesia and it's going to work, and it does work, but it doesn't work on the tooth on which you have to work, right? And then you have to tell the patient, oh my god, you know what, I think you have a very hot pulp. Basically this tooth is getting refused to be anesthetized, though all the other areas are anesthetized and the block has acted. So now you have to give something extra, an adjunct, so that the nerve of this tooth gets anesthetized, because the patient is still having a lot of pain. So normally the first step you do is STA, that is single tooth anesthesia, which is basically nothing but an intraligamentary injection. I'm sure you must have encountered such a situation in your clinic, and definitely in a month 2-3 such cases come, a very hot pulp, and no matter what you do, it just doesn't get anesthetized. So you have to give intraligamentary injection, which works in 99% of case. What you do is you just take the needle, a short one. If you want to bend it, you can bend it at 90 degrees, and you insert in the PDL space. And with a very forceful pressure, you inject the local anesthesia. And you do that on the labial side and the lingual side. And then the tooth, 99% should get anesthetized. If it still doesn't, then the second option is you give an intraosseous anesthesia. Basically, you put that needle at 90 degree in the bone, somewhere near the cemento-enamel junction or a little below it, and with a lot of pressure you have to pierce the bone. But because that area is already numb, the patient does feel something but not so much of pain. So the needle goes through the gums and through the bone, and then you deposit the anesthesia. Now that should definitely work. Even if that doesn't work, then God help you. So intraligamentary is the first step, which is also called as a single tooth anesthesia or a wand technique, if you have used that wand kind of a thing. Nowadays, usually in practical dental application, mostly people start with intraligamentary injection. If that doesn't work, they proceed to inferior alveolar nerve block. So because single tooth anesthesias work very nicely if given properly, like labial, lingual side, adjuncted with a bit of intraosseous one. You don't have to give a block. But since a block is the traditional method and still it's practiced widely, if that doesn't work, then the supplementary injection that would be most effective to ensure pulpal anesthesia prior to commencing treatment for tooth number 4-6 would be an intraligamentary injection adjacent to tooth 4-6. That's your option D. Option A is another inferior alveolar nerve block in a more superior position. That's not a right option because your block has acted, and the key word here is profound anesthesia is achieved. So option A is out of question. If there was no profound anesthesia achieved on the tongue or the lower lip, then you would have chosen to give option A, but that's not the option here. An infiltration in the lingual sulcus of tooth 4-6, no, that's not going to help you. A buccal infiltration distal and below the apex of tooth 4-6, no, that's not going to help you either. The only thing that will help you is intraligamentary injection. That infiltration, option B and C are good when you're extracting a tooth. You don't need to anesthetize the pulp of the tooth when you're extracting the tooth. You just need to anesthetize the PDL spaces. But here we are treating the pulp, not the PDL. So giving an infill is useless, right? Let's go to question number 32. Very classical scenario, you will encounter such kind of scenarios monthly basis, like sometimes 4, sometimes 5 cases. You just have to take a deep sigh and pre-inform the patient that if you have a hot pulp, my INB is not going to act and you'll still get one shot, and sometimes you even have to give it inside the pulpal tissue once you open it because it's still so sensitive. So a shock-like experience the patient will have, which definitely makes everybody dread the root canal treatment because that pain is very sharp-shooting, horrible, mind-boggling pain, but it is what it is, So when completing a risk assessment for the endodontic procedure, what is a risk assessment? You see how risky the procedure is basically, right? And how much risky it's gonna be for you. The patient is just opening the mouth and sitting. You have to do the risk assessment. Is it a straight canal? Is it a calcified canal? Is it a curved canal? How is the location, axis, basically obstacles for you for obturation. So you're doing a risk assessment as to how much headache this tooth is going to give me, kind of like that. You noted that the pulp chamber of tooth 4-6 appears receded. That means the pulp chamber, if it's this much, it's reducing because a lot of tertiary dentine has formed. As it is, the patient is 52-year-old. So that can happen due to pulp calcifications. Now, what anatomical landmark can most predictably assist you to locate the floor of the pulp chamber of tooth 4-6? Usually, the floor coincides with the cemento-enamel junction. Now, cemento-enamel junction is usually 1 to 2 mm below the gingival margin of the tooth if the periodontium is sound. So what you can do is you can take your burr and you can measure the height of it, like the entire structure of the tooth, and then you can place it inside, because if you cannot find the pulpal chamber where it was supposed to be because it's receded, you don't want to perforate the floor accidentally. Because normally in a good tooth, when you just breach the roof, you get a drop and there is quite some space and then you can see the floor. But when the receding of the roof has happened, so from this gap, so this is the roof and this is the floor, sometimes it becomes just this much. So now you're digging in, and sometimes you do get a drop, but you just don't feel it because the floor is right here. So you don't actually get that space feeling of the burr moving, in vacuum in a healthy young pulp. So when the roof is here and the floor is here, like very next to each other, and you're drilling and you're wondering, you don't want to perforate the floor accidentally. How do you know how deep you are? You cannot keep taking x-rays all the time. So the easiest way is you just take that burr and you place it outside the tooth and you place it near the gingival margin, and you see the length of the burr, and then you place it inside the tooth, and then you check. Like, you can actually put a stopper on the burr if you want. Take the stopper from the file and insert it in the burr, a long burr, and then you can measure how much deeper you have gone. If you think you are nearing the depth where the CEJ is supposed to be, then you're almost reaching the floor. Then you just have to find the canals, and because they're calcified, it's not easy to locate. Best is refer to the endodontist. Let it be their headache. But if you are the endodontist, then you exactly know what I'm talking about. And for a general practitioner, the freshly passed out BDS graduates, calcified canals are your worst nightmares. Try not to take such cases. But yes, of course, endodontics is a very fulfilling specialty, and I was myself considering it at one point of time. I love endo. I love endo in young teeth. I don't love endo in calcified teeth. So anyway, so this is how you do the measurement and what is the most anatomical landmark that's going to assist you is the level of cement to enamel junction. That's the CEJ. That's option D again. Understood? The rest of the options don't help you out. After determining the working lengths, you plan to clean and shape the 4 canals of the tooth forceps utilizing 1% sodium hypochlorite solution as an irrigant. What step in the irrigation technique is the most likely, which means all the options are correct. I have to choose the most likely. They're adjectives. ADC loves adjectives. They would like to give you all the options which are correct, and now they want you to choose the most likely. To improve the ability of the irrigant to effectively remove both the pulp tissues and biofilm from the entire root canal system. Using a static irrigation technique in the apical area. Static means you just place the needle and you just press the piston and release the irrigant. No, that's not going to help you. You have to move the needle up and down. So static irrigation is not a great idea. Positioning the needle tip in the apical third of the root, right? If you go deep inside, then you kind of clean all the entire area. Increasing the positive apical pressure with the syringe plunger, no. Allowing the needle to bind slightly to the apical canal walls, definitely no. You don't want the needle to bind it. You need some space. If the needle is binding, then it's going to create a lot of pressure below the needle, which can cause a lot of pain, and sometimes if you're treating maxillary teeth, it can just go in the sinus and it will be a horrible accident that is happening, the hypochlorite solution in the sinus. So the needle should never bind to the canal walls. It should be free to move. It should be a thin needle with lateral perforations so that the solution is coming out laterally and not just being forced apically. You have to keep on moving the needle up and down and try to place the needle very close to the apical third. So that is the right answer, which is the option B. I'm sure by now you know how to irrigate and what needles to use. So as such, this is not a difficult question. It's an easy question to solve. With his symptoms managed and healing progressing well, George attends his tooth forceps obturation appointment. Okay, so you finished BMP. You placed a dressing in collagen for obturation. You plan to place a resin sealant, cement and gutta-percha root filling using a lateral condensation technique. Okay. What procedural step when obturating the root canal is most likely to reduce the risk of vertical root cracks and fracture? Fair enough. So basically you have the roots all prepared and you're doing a lateral condensation technique. You still don't have that, warm gutta-percha where you compress and it gets liquefied and you just withdraw it, You're using the traditional lateral compaction technique. So how would you reduce the fracture to the root? Because now they are hollowed and you have reduced a lot of dentine to clean the tooth. So if you're going to put the gutta-percha and press it against the walls of the canal, so if this is my wall and I'm pressing it, like this, then I'm going to fracture that wall. So I will direct my forces which are away from the axial wall. So my compression forces should be away from the canal walls. That's option D. That's the right answer. The rest of the options are not correct. That is how you do it. If you try to compact the gutta-percha against the wall, like you're putting the pressure in the direction of the wall, then definitely you're going to fracture the root. And you don't want to do that. And the last question for today, after completing the root canal treatment, you are planning the final coronal restoration for tooth 4-6. Okay, you finished your obturation, you're happy with it, and you're planning the final coronal restoration. What is the most important factor that should be considered during treatment planning for this? See, this is a question where a lot of people get confused and make mistakes. Here, when you are doing a final coronal restoration, it doesn't matter this tooth is having a root canal or not. You have to treat this tooth like any other tooth. You are putting a crown possibly, or an onlay, or an inlay, or you're just simply doing something else. But any restoration, the basic principle of any restoration to last is that it has to be placed on a sound coronal tooth structure. If the remaining tooth structure is not enough or it is not sound, basically it's decayed or it's defective, then your restoration is not gonna stay and a micro leakage will start, eventually leading to your root canal failure. You understand? So the most important factor, that's what the question is asking, the most important factor that should be considered during treatment planning for any coronal restoration, I would say not just this final coronal restoration, is the adequacy of the remaining sound tooth structure. If there are 3 walls missing and only 1 wall is sound, you cannot give an onlay. You have to kind of build up, you have to give a post and core and give a crown. If the 4 walls of the tooth are intact, very good sound tooth structure, and you made that ideal endodontic axis opening, then probably you can just give an inlay. Or maybe if just one cusp is missing and the rest of the tooth structure is very robust and strong, you can possibly give an onlay. But if the tooth structure is very weak, then you have to give a crown. So what makes you decide that final restoration material is the adequacy of the remaining sound tooth structure and nothing else. That is the most important factor. You understand what I'm saying? So this is the question. This is a very common question. This is the bread and butter of any dentist, a root canal treatment, right? And you should know what to do, how to do to make this treatment a success. Usually it's a 94% success, any root canal treatment. It's mentioned in the Clinical Oxford Practical Dental book. If you have time, do read through that. It's a very nice book. It will help you a lot. It's a scientific procedure. Never ever any procedure is a 100% success. It's a 94% success. But it's okay. It's a great success rate. But you have to inform this to the patient. And how do you study for ADC exam? You go through all the past papers. We have 33 of them at the moment. And you have to have very strong basics, which you can do with my Ultimate ADC Companion book and the comprehensive book. The ADC written exam, I would say, is divided into 70% of the dental questions and 30% their own questions meaning therapeutic guidelines, ODEL, ethics, motivation interviewing, the resources of which they have clearly given on their own website. But you have to, of course, go through the books that they have mentioned, and I have simplified that work by making clinical scenario questions like these from those books which they have recommended, so it's easier for you to solve and get prepared for the exam. I'm happy to share the sample copy of these 2 books. If you email me, I'm writing the email address in the description below this video. You can just email me. I'm happy to share the course details and the sample copy of the book, and then see if you like it, and then you can just get it from me. So I hope this was nice. I liked this question. It's a daily bread and butter question, and you should be knowing this. This question will fall easily in the treatment planning cluster. If you have any other questions, feel free to message me. And I know I'm shooting this video almost after 10 days. I do plan to shoot videos every day, but life is life. I went to India for a week. I had to be there. And when I came back, both my son and my husband are down with viral fever. And yesterday night, I was just up till late and just putting both of them to sleep and giving them medications. And I'm still working full time because I had taken a break for a week. I visited my home almost after 8 months. I have a lot of backlog of patients, and so I just cannot take leave from that at the moment, because even those patients who are waiting for me to come back, many children having swelling and pain. I'm blessed, I'm grateful for that. But yeah, sometimes, a toddler mother does get exhausted. I mean, all those parents who have toddlers can relate to me, I guess. But it's okay. What I want you to take away from this thing that I'm sharing is that just keep going on. Just be strong. you have a lot of energy in you. You just have to access it. And like I keep praying most of the time that Lord, give me the energy just to go through all these things every day, and at the same time give it back to the community, like how I'm doing with this video. I want you all to succeed, and so I'm making this video to make you understand how to solve each question and be a good clinician. So yeah, looking forward to your comments. It's always nice to read them. Have a nice day. Bye bye.